to introduce Gruschen Veldtman. I think he does not need an introduction. He's an expert in single ventricle physiology. To be honest, every time that I'm seeing a patient with a single ventricle and I see the liver on my echo, I think at Professor Gruschen Veldtman each time when I'm looking at the echo images, because he knows a lot about the liver and the single ventricle physiology. Professor Veldtman is currently working in Riyadh, Saudi Arabia, and I think the audience is waiting for your talk. Gruschen, please.
Werner, thank you for the kind introduction, and what a pleasure to see you and Yolin, even from across the desert. I'd like to welcome back all the people who are attending this wonderful meeting, and particularly people from all over the place, including my old place where I worked in Southampton, but also as far afield as Canada, Japan, Sao Paulo. So welcome back, everyone. The details of my talk are, I'll be speaking about the peripheral organs and how that can help us in prognostication in congenital heart disease. So as we are all aware, the adult congenital patients are aging, and I was impressed to learn that the average age of the adult congenital patients in Germany, for example, is now well into the 60s. And as we know also, there's cumulative evidence of organ disease as patients age. And on this graph, you can see a greater prevalence of COPD, diabetes, cancer, arthritis, just as an example. And this is hardly surprising when we look at the physiology of what's happening in each of the organs. And on this slide on the left-hand panel, you can see the degree of blood flow to each organ at rest. And you can see in the solid bars, that's a young patient, and in the lined bars, those are older patients. And you can see that blood flow is significantly reduced at rest. And this actually becomes enormously exacerbated during exercise, as you can see on the right-hand panel. So not surprisingly then, we can see an increase in mortality as patients age with congenital heart disease. And in this slide from Korea, I believe, you can see simple congenital heart disease is indicated in orange, complex congenital heart disease in gray, and the normal population in blue. On this panel here on the left side, these are young patients in their 20s, compared with the older patients in their 50s to 60. And you can see that as patients are older, there's really a significant increase, as is expected, in mortality. So end organ disease then may be primary, related to a primary disease in the end organ, as we see in, during aging. It may be secondary due to the congenital heart defect or other problems in the cardiovascular system. Or, of course, it may be due to a combination of both of these factors, as we will increasingly see as our population ages. Michael and Aidan Bolger produced this wonderful slide, which just indicates the natural history of congenital heart disease with surgical modification in the early phases, and then a general decline and during adult life or later on, perhaps needing reoperation, medical intervention, and then getting to a stage where the patients develop inoperable disease. And our task as physicians is to see, can we actually predict when these late outcomes occur, and can we intervene prior to that? And particularly, can we intervene prior to the onset of inoperable disease? And our question today is really, can we use the end organs to answer that question? Now, this relates really to medical prognostication, as we discussed earlier, which is really a very neglected field in current medicine. And just to give you a flavor of what happened in the 14th century, so if you saw a physician at that time, they would look at your name. Each letter of your name alphabetically would be assigned a numerical value. You would add to that numerical value the day in the lunar month that you are born, so that will increase your value. And then you would also see on which planetary day you were born, and that will give you another value. You'd add these all up and you divide them by 39, and you will have your magic number, which you can then add into this wheel or sphere that will then predict what the short-term and late-term outcomes will be. Now, clearly, we haven't the tools even today really to predict accurately what the outcome is. I'd like to share this patient of mine with you, who's a 47-year-old gentleman with unrepaired tetralogy of Fallow, at least when he presented, and really just ask you to think a little bit about the prognostic factors in this patient. So he was referred to us with heart failure and cyanosis and poor effort tolerance. Clearly on imaging, he had unrepaired tetralogy of Fallow, and his saturations were surprisingly good at 92%, but he presented in congestive heart failure with ascites, peripheral edema, and orthopnea. After much discussion, he eventually underwent tetralogy of Fallow repair, and initially had a rather post-op stormy post-op course, and then gradually improved and was discharged home on a heart failure cocktail and diuretics. This was his baseline ECG, and you can see there's right atrial enlargement, perhaps biatrial enlargement actually. There's some right axis, which is minimal, and generally the forces are small. The very next day, he was in atrial fibrillation, as you can see, which is a rather coarse atrial fibrillation. And this is his chest X-ray, and you can see his heart is clearly enlarged, and there's a little bit of splaying of the carina here, large central pulmonary arteries, as you can see. And there's also evidence of perhaps pulmonary venous congestion. There's some curly C lines and also a little bit of fluid in the interstitial fissures. This was his last cardiac catheterization, which I'll share with you. His RA pressures were 33, his RV systolic 78, PA systolic 85, mean of 54. His wedge pressures 39, and his arterial pressures are as indicated. And clearly his cardiac output also, or cardiac index, was also low. So perhaps I shouldn't even ask this question, but what do you think is a gentleman's 5-year prognosis? And then pertinent to this talk, what is, would end organ assessment help us in this prognostication? And please feel free to put your comments and thoughts on the chat line as you gather your insights. Now, the heart and cardiovascular system are intricately linked to the peripheral organs. I think we all know that. The cardiovascular system may be limited in its ability to increase in stroke volume, as we see very commonly in congenital heart disease. There's frequently chronotropic incompetence related to prior surgery and damage to the autonomic system. Diastolic reserve, which we're learning a lot more about in our patients, and this may be significantly reduced. And also reduced pulmonary vascular reserve, which I believe for patients like those with single ventricle or tetralogy of Fallow, pulmonary atresia, and so on, may be quite abnormal. And this may lead to poor coupling between the right ventricle and pulmonary artery, and then abnormal downstream responses, as Werner talked about, in terms of atrial strain in the right atrium and the liver causing congestion. So this reduced reserve and abnormal response in the cardiovascular system has the potential for triggering these phenomena, hypoxemia, mechanical transduction, and inflammation. And this profoundly influences the peripheral organs, including the lungs and respiratory muscles, skeletal muscles, the hematologic system, the kidneys and liver, and so on. But this is not all. The organs then in turn contribute to what happens in the cardiovascular system by in turn turning on their paracrine and endocrine and neurohormonal systems, and does this via activation of the hemostatic system, excuse me, producing a profibrotic milieu, endothelial dysfunction, and abnormalities of the microbiome, not only in terms of bacterial translocation, but also in totally changing the biochemical signaling that comes from the gut. So really, what we've got is a closed system in which the heart and cardiovascular system interact profoundly with the peripheral organs, and the peripheral organs in turn interact profoundly with the cardiovascular system. So over the next few slides, I would just like to look at some mechanistics with you. So this is work from Katie Coleman during my time in Cincinnati, and we'd used peripheral venous pressure monitoring, as you know, in Fontan patients, but this principle is equally applicable to heart failure syndromes in general, I believe. And here's an example of resting pressures, unloaded pressures in blue, and then as patients exercise, up to peak venous pressures. And in Fontan's, this reflects, of course, the pulmonary artery pressures. And as I indicated to you earlier, there's a reasonably close correlation also with the pulmonary vascular resistance index. Now, there can be no doubt that hemodynamic lesions contribute to the stiffness or the mechanical stress that the end organs face. And here's the liver in patients with Fontan's who have severe atrioventricular valve regurgitation versus those that don't have AV valve regurgitation. And you can see the liver stiffness is significantly increased. And patients with Fontan failure equally have higher liver stiffness at rest. But this is not all. And here's what happens in response, or at least associated with this, is these changes in mechanical transduction produces enormous changes in signaling mechanisms. And here's a very profibrotic milieu produced. And here you can see metalloproteinases, which are elevated 2, 8, 10, 13, and TIMP4. And you can see in this block here under PCP, for example, this is patients with reduced liver stiffness. This is patients with increased liver stiffness. And you can see this mimicked across each of these metalloproteinases. And this fibrotic milieu affects the heart in turn. It affects the liver backwards again, and produces a new cascade of events that's detrimental. Yulene already showed some of this, but what I wanted to point out is that these changes in the cardiovascular system produces gut dysbiosis and bacterial overgrowth, and also changes very much the signaling that goes from the gut. And I think we're learning a lot more about this in the last year to 2 years, and I think there will be interesting work that needs to be done in the congenital population. But here's Sasha's work across a whole spectrum of congenital heart defects, and you can see CRP above 2.98 is very prevalent in our patients, and perhaps those, interestingly enough, with simple shunts, but these are complicated ASDs, I suspect, and Epstein's and so on have perhaps the highest levels of inflammation. And as Yulene showed, this is clearly associated with mortality and also with hospitalization. Now, turning our attention to the kidneys, clearly the kidneys have an enormous and close relationship with the heart. And when there's decreased cardiac output or abnormalities in pulmonary vascular resistance, heart rate, increased venous pressures, abnormal lymphatic drainage, the kidneys may be profoundly affected as they change their neurohormonal activation, their sympathetic tone, local endothelial function, and also producing a fibrotic milieu, which actually causes renal fibrosis and perhaps chronic renal insufficiency that is irreversible. Now, I'm not going to go into much more detail about this, but accepting to say that estimated GFR is an important consideration as to how you measure it. And here's Sasha showing that when you use cystatin C to estimate GFR, it's perhaps a more accurate way and gives you good insight into mortality risk for patients. But even so, estimated GFR is not the end-all of this, and new markers such as KIM1, NGAL, and so on may be more insightful of tubular damage and also give a better idea of prognostic indication. So here's our patient again, and this is his renal function over a period of time when he first presented to us in 2017. And you can see his urea creatinine had a bump at that time with a dip in his GFR. And over time, his GFR sort of gradually decreased to the beginning of 2020. And here he had a real dip in his renal function at this point in April, excuse me, of this year. And then again, something happened at this point. But what I also want to point out is that rapid changes in GFR like this are not necessarily prognostic of outcomes. And I think if we look here at other biomarkers like KIM1 and NGAL, maybe that will give us better insight. And this has been demonstrated also in the SOLVED trial that perhaps at this stage, this may be an indication of diuresis that's changing renal function at this point and not necessarily prognostic. Let's turn our attention then to the liver next. And as you know, there are multiple and complex mechanisms involved in how the liver changes in Fontan circulation. Antenatally, there may be abnormalities in genetics, and we know that some genetics alter the structural drainage, for example, of bile from the liver and may cause structural changes that can be triggered by hemodynamics. There may be perioperative, postoperative insults, and then later on, as we discussed, changes in venous pressures which may cause mechanical stress and mechanical transduction, abnormalities in lymphatics, and also importantly in situ thrombosis. Now, there can be no doubt that the liver plays an important part in prognosis in Fontan patients. This is work from Rob Alder when he was still in Atlanta, and you can see patients that have portal hypertension or have a 9 times increased risk of meeting the endpoint, which is death, hepatocellular carcinoma, or transplantation. And this is work from Angie Yateman a few years back now, and she demonstrated that liver disease is not only progressive over time, but also that patients with cirrhosis at baseline have a higher risk of death, transplantation, encephalopathy, and decompensated cirrhosis. But we must not forget that the liver in turn also affects what happens in the heart. And we know that diastolic dysfunction, hyperdynamic state, QT prolongation, eventually systolic dysfunction in addition to diastolic dysfunction, and also electromechanical dysynchrony, which we see in many congenital defects, especially in single ventricles, may occur purely as part of what happens in the liver. So this is what I use then for risk stratification in Fontan patients as far as the liver is concerned. So low risk features are essentially normal fibrosis markers, liver parameters, and for serum, for intermediate risk, progressive rises in bilirubin, gamma GT, and also the fibrosis scores. And high risk features, really patients with high bile acid levels, and of course patients with a high AFP, so alpha fetoprotein levels. As far as imaging is concerned, we're looking at the stability of lesions that we see. Greater than 1 year stability is reassuring. Lesions less than 1 centimeter. And then features of classic regenerative nodules. So these are hypervascular nodules, essentially, which have a very small chance of transforming into something malignant. And then intermediate features, we know that if these lesions then change in terms of their hepatocyte phase intensity, or that there's a rate of growth that is faster than 0.5 centimeters per year, or there's progressive changes in liver stiffness or the liver substance characteristics. These are considered intermediate features. And then high-risk features, of course, are features like these that suggest a hepatocellular carcinoma or large lesions, or in fact, of course, a positive histology associated with it. So coming back then to our gentleman, he developed progressive decline in his GFR eventually. He also developed ascites. He had signs of chronic liver disease. His albumin was very low, and I'm not entirely sure whether this was due to nutritional deficiency or a problem in liver function. He had significantly elevated bile acids. And eventually we readmitted him in intractable heart failure, and he was really in a very serious state. So I would like to conclude then and say adverse cardiovascular hemodynamics interact directly with an array of mechanisms that trigger end organ disease in the lungs, skeletal muscle, kidney, gut, and liver. In turn, these organs profoundly affect what happens in the cardiovascular system. They play an important role in prognostication. In future, organ-specific biomarkers will help us a lot. And end organ disease in the liver, kidney, and gut should be a serious call to arms in order to optimize hemodynamics. And just a final comment about the future, as I see, I think interestingly for our patients, as everyone has mentioned already, a kind of precision medicine is on our horizon, where we can assess patient and organ-specific omics, particularly proteomics, but also in association then with genomics. And we have already started a couple of trials looking at proteomics in PLE patients and how they respond to therapy. And with that, I would like to conclude and thank you for the opportunity to speak.
Thank you, Gruschen. This was an excellent presentation, and of course, I expected that from you. But again, great presentation and looking at all the several organs and explaining again a lot of things. So thank you.
Thank you, Lynn.
I have just one question.